Hello. I would like to thank the AIUM for giving us the opportunity to present our research despite the annual 2020 meeting being canceled. The title of our research is Outcomes from Ultrasound-guided lidocaine hydrodissection of post-surgical or post-traumatic patellar retinacular scar. I'd like to thank my co-investigators for helping me with the project as well as with the PowerPoint. These are my disclosures. Anterior knee pain is a common complaint, particularly in young, active people. The pain can interfere in everyday activities, particularly exercise or athletics. Scar formation is a known complication of injury or surgery. Up to 25% of patients who have patellofemoral instability or dislocation have persistent pain after surgery, a subset of which are localized to the retinaculum focally or to an arthroscopic port. In a study from the American Journal of Sports Medicine in 2000, we see surgical resection of localized segments of painful retinaculum in patients with refractory anterior retinacular knee pain had 88% moderate to substantial improvement after surgery with a long-term follow-up. The current standard of conservative care treatment for patients with patellofemoral instability or dislocation who have persistent post-surgical post-traumatic pain and retinacular scar formation is physical therapy targeted to soft tissue mobilization, balance of the entire kinetic chain, and restoration of patellar homeostasis. In the event of failed physical therapy or painful knee after surgery, there has been no diagnostic criteria or therapeutic treatment using ultrasound for retinacular scar described in the literature. The purpose of our study is to assess the use of ultrasound-guided hydrodissection plus advanced soft tissue physical therapy to reduce pain and improve function in patients with painful post-surgical or post-traumatic retinacular scar. We retrospectively studied patients with anterior knee pain from retinacular scar who failed conventional physical therapy and subsequently underwent ultrasound-guided patellar retinacular scar hydrodissection, followed by an advanced soft tissue physical therapy protocol over a 4-year period. Pain severity, return to baseline function, and requirement for subsequent surgery was recorded. The results were compared between patients who followed the complete post-procedural protocol, who were put in the compliant group, and those who did not complete the protocol, who were put in the non-compliant group. When ultrasounding the patellar retinaculum, we scan in both the longitudinal and transverse plane from above the patella to the insertion of the patellar tendon. Most of the scar is found along the anterior portion of the retinaculum in my experience. However, we always scan the area of pain as well. We also perform something called a squeeze test, which manipulates the underlying fat by massaging the soft tissues adjacent to the transducer while scanning over the area of scar to assess for any tethering of the scar to the underlying fat. This ultrasound is an example of a normal retinaculum. You can see between the blue arrows there is a strip of tissue which is hyperechoic on this ultrasound, extending from the patella to the femur. The echogenicity of the structure, however, will depend on the angle of the transducer, and we're also looking at the smooth margin of the superficial and deep edges of the retinaculum to determine whether there is scar present. In this example of retinacular scar, again between the two blue arrows, you can see the retinaculum is thickened and has linear areas of hypoechogenicity within it. The superficial margin of the retinaculum is also mildly blurred without a sharp definition. In this type of scar, you're seeing a thickened retinaculum between the two red dots I just drew. And then you can see some dystrophic calcification within this retinaculum. Then the blue circle is designating this amorphous area of hypoechogenicity and shadowing, which obscures the deep margin of the retinaculum and extends into the underlying fat. When we perform the dynamic exam of the fat, what you'll notice is the fat moves smoothly underneath the retinaculum without adhering to the undersurface. In this example, what you can see is a thickened retinaculum with irregular margins, and when we do the dynamic exam, the deep fat moves with the retinaculum without separation, consistent with adhesions. We retrospectively reviewed 96 patients with painful retinacular scar. 37 of these patients underwent ultrasound-guided hydrodissection. 9 were lost to follow-up. The final sample consisted of 33 retinacula and 26 patients with a mean age of 27. The hydrodissection was performed with the patient supine and the knee supported with a rolled towel if more comfortable for the patient. The rolled towel was not necessary, however. We use a 25 or 27 gauge 1.5 inch needle and an average of 3 cc's of 1% lidocaine, first injected superficial and then deep to separate the retinaculum from surrounding scar. Finally, we would do post-injection squeeze test to ensure that the fat was detethered from the retinaculum. When we're doing the hydrodissection, as I mentioned earlier, we do start with a superficial injection. This is to anesthetize the patient, as this scarred retinaculum is very, very tender. You do have to be careful that you get all the air out of your needle prior to doing this, as you can obscure then your deep injection, which is done subsequently. In this patient, you can see there's a small area of fat that still remains tethered to the retinaculum. We try during the injection to get as much of that off as possible and hope that if we can't get it off, the manual therapy will remove it. This is an example of a deep injection which demonstrates how stiff the retinaculum is. As I pull the needle out, you can see how the retinaculum just comes with the needle. The image on the right demonstrates the complete detethering of the retinaculum, as you can make a smooth line along the undersurface. So 67% of the retinaculum were in the compliant group. Overall, the pain score decreased by 6 points, which is significant, with 82% of the retinacula cases achieving greater than 75% subjective return to baseline function and only 5% requiring surgery. This is in comparison to the non-compliant group, which did have a decrease of pain by 2 points, which is also significant. But none of them achieved return to baseline function, and 45% of them required surgery. So in conclusion, ultrasound-guided hydrodissection plus advanced soft tissue physical therapy of post-surgical or post-traumatic retinacular scar leads to reduced pain and improved function similar to surgical outcomes in the literature. Longer follow-up, larger cohort studies are needed to assess long-term success. These are our references. Thank you for your attention, and this is my email at the bottom if anyone has any questions.